today we'll just go through the, I call it a master class, but it's just actually just a little bit of few cases to understand when we in pathology do lymphoma pathology, what it means. So the first few slides will be, prerequisite, the normal histology of nodes. Then I'll discuss a little bit of a reactive pattern and how they mimic lymphomas, a basic immunohistochemistry pattern, benign versus malignant. I'm sorry, this slide is from Hodgkin's, but it is non-Hodgkin's lymphoma, and a little bit of conclusion. So before you look at any node, it is essential to understand that nobody biopsies a normal node. So there is no perfect picture. It's a most dynamic tissue. So the patterns of reactivity in so many different people are so many different people. And it's overwhelming, and it's so much overlap with lymphoma that sometimes we have a problem in diagnosis. The site also influences histology. For example, sinus histiocytosis is a normal finding in mesenteric nodes, and pigmentation, hemosiderin, they're all very common in mesenteric nodes. Mandibular lymph nodes are exposed to antigens from the oropharyngeal diffuse, so the secondary follicles are very well developed, and they naturally have plasma cells and plasmacytosis. So you shouldn't be making a diagnosis of a plasma cell disorder in a mandibular node. And popliteal and axillary nodes, sometimes, they are very unstimulated. So if you get an enlargement there, that is definitely significant. So the lymph node as a structure, it's not just a mass of lymphoid tissue. If you read normal histology, it's so amazing that it's a ball of cells that have definite traffic control. That means you see this compartment. So basically, it is divided into the germinal centers, the paracortical compartment, the medulla. Now, each of these centers, the flow is not passive. There's an active process. So there's a traffic control, I say. So all of these cells will allow flow in only one direction. So, and they will not go, for example, if something goes in this direction, nothing will go in that direction. So that's the efficiency of the system. And that is the reason why it performs its function so efficiently about immunity and also filtering the foreign antigens. Now, this is how a normal histology looks like. So this is, remember what I showed you earlier was a very perfectly cut node, but we never cut nodes so perfectly. So sometimes that perfect picture is missing, but maybe here you can see that ideally you're supposed to see a hilus to the node. But when I was taking this lecture, I was hunting for a perfect node. I didn't find one. So you need a hilus. And from that hilus, the paracortex is actually composed, the cortex is composed of these germinal centers. You can see these are the germinal center, and between the germinal centers is the paracortex. And the medulla is supposed to be here, but as I said, this node is not cut right through the center. It's cut a little tangentially. So that's why you have a little different picture there. So let's look at each of the compartments of the node. So the cortex, as I said, you have germinal centers. And this is the medullary cords. Now, these are the medullary cords that you can see there. And that's an afferent serins which is getting into the node. And let's look at the higher part of these cells. Now, you can see this is a germinal center. As I said, this is not a perfect node, but it is as perfect as it gets. And these are your mantle zones around them, and these are your sinuses. So that's how a normal node looks like. Now let's look at the germinal center. Now, if you look at a germinal center, it's a B cell zone. It consists of germinal center cells, which are B20 positive, 10 positive, and BCL6 positive. Now, what is the function of the germinal center? It's obviously to produce new antigens. Now, it is interesting that this germinal center is not perfect, but it shows a light and a dark zone. The dark zone is composed of the centroblast, and the light zone is composed of the centrocyte. When you read these, it's so interesting that the centroblasts are the ones that give rise to centrocyte. So the stimulated memory B cell, when it is responds to when it gets the perfect fitting antibody to the corresponding antigen, it undergoes a centroblastic transformation. And you see these large cells over here, those are your centroblasts. Then these centroblasts divide into centrocytes. They go to the germinal center, and the centrocyte with the most affinity, highest affinity receptor, only that one stays, the other one dies, and one goes back into the mantle zone as a reservoir. So what happens is you have a lot many. So for every one centroblast, you have at least 3 centrocytes, and that's the reason they have to be removed from the germinal center, or the germinal center will become very packed. So that's the reason the macrophages are here to kind of destroy these cells. So this is what we call. So this is a centroblast. There are macrophages there. The small non-cleaved are the unstimulated naive B small cells, and the small cleaved are the centrocytes, and the large cleaved are the non-cleaved large cells are the centroblast. Somebody's mic is on, and that's probably interfering with the thing. So now we come to the, where is my mantle zone one? That is one thing I forgot. So there's also a mantle zone here, which is mantle cells, which is made of IgD. So what happens in the germinal centers? The immunoglobulin is only cytoplasmic. The mantle cells develop because of the switch in the antibody. They develop the surface IgD antibody as well. Now, this is the marginal zone. You see, that's the germinal center, that's the mantle, and that's the marginal zone. That this is the reservoir of memory B cells, which already are inclined towards the specific antibody. So what happens is, when a cell gets stimulated, there are some places in the body. Marginal zone is not present in the all lymph nodes. It's only present in splenic tissue and some mesenteric lymph nodes. So they are like a reservoir for quick response. So in normal nodes, you get just the mantle and there are some few stimulated cells there. But in a marginal zone, it is heavily laden with memory cells which shows antibody. These are not really plasma cells. This is one step before the plasma cell. So this marginal zone, if you find in a normal node, then something is wrong with these things. Coming to the paracortex is the site for all the T cell responses. It's a T cell rich area. It's composed of this, what we call as a high endothelial venules, T cells, and dendritic cells are that's the network that ensures the traffic control that I was talking to you about. And as I said, this is how it is. You have high endothelial venules, you have chemokine receptors, and only what happens is they have integrins and glycoproteins that preferentially allow the filtration of T lymphocytes, and this is all modulated by interdigitic reticulum cells, plasmacytoid dendritic cells, and histiocytes. So the medulla is where all the plasma cells are, and this is like it's like the filter. Paracortex is responsible for the immune response, whereas medulla is a filter that makes sure that whatever goes up out of the node is not any harmful substance. Now, medulla is rich in interdigitating reticulum cells, and this is the site for most of these sinusoidal changes that you see in a lymph node. Now, this is how your medullary, there are some plasma cells. This is the plasmacytoid dendritic cell in the lymph. So the basic panel in lymphoma, now we do what we call as LC or lymphocyte common antigen. It's also called as CD45. That's positive in all NHL except, maybe we go to the other part later. And once LCA is positive, now this is very useful in extranodal lymphoid proliferations, where if you get LCA positivity, you know it's a hematolymphoid neoplasm. Then we put a B cell marker and a T cell marker. The B cell marker, if it's strongly positive, it has to be 3 times. If you have 3 and 20 positive cells in a node, the B lymphocyte should be at least 3 times the T lymphocytes to say that this is an abnormal B cell proliferation. Then we look at the cell type and we decide to put a low grade or an aggressive B cell panel, and we'll just go upon that a little later. Then the T cell, unfortunately, what happens is positivity means just CD3 positivity doesn't mean anything, and we have to show aberrant antigen expression to call something as a lymphoma. So we just don't do one CD3, we do 4, 8, and 7 as well, and we'll see how we use it. And then accordingly, we put follicular helper T cell markers, ALCL markers, and NK T cell markers. We'll go to that algorithm in a while. Now, there are certain lymphomas or hematolymphoid tumors that are negative for LCA. So if you're thinking of these lymphomas and your LCA is negative, then you have to put a specific panel. Otherwise, you'll mix out hematolymphoid. One important thing is the Hodgkin cells of the RS cell of a Hodgkin's lymphoma is LCA negative. Many of the AIDS-associated lymphomas like plasmablastic lymphomas are LCA negative. ALCL 50% are LCA negative. Plasma cell tumors, myeloid sarcomas, very rarely we've even seen DLBL, especially in the medial channel, because it's closer to Hodgkin's than the other DLBLs. It often shows you LCA negativity. Then, if everything fails, if none of these markers are positive, then we put a CD30. As I said, ALCL to make a diagnosis of ALCL. The next marker we put is a dendritic cell marker, which is if this also fails, and that is 21, 23, and 35. So these are the dendritic markers for you. The myeloid markers, we don't have robust myeloid markers in our histology because they are actually better done on flow. But we put c-KIT, MPO, CD15, and CD34 as a myeloid marker. The plasma cell markers we put are CD138 and kappa lambda as a sign of risk. So now let's look at the immunohistochemistry in the node. So as I said, traffic control. So B cells in a normal reactive node are concentrated around the germinal centers, the mantle cells, and you'll always see some scattered C cells in the, B cells in the paracortex. Now the in the medulla and paracortex. This is the paracortex. Now this is, as I said, the node is not, normally the paracortex is between the germinal centers, but here you can see that it is tangentially cut. So the non-stained areas are the 3 stained areas, as you can see here. So I repeat, germinal center mantle stained with B cell markers and the paracortex stained with T cell marker, because those are the overwhelming processes. There are some germinal center T cells which we call as follicular helper T cells, and today we know that there is an origin of follicular helper T cell lymphomas, and that's why you see a sprinkling of T cells on CD3 in the germinal center. Now, this is the BCL2. BCL2 is positive in all T cells. Now, in the normal B cells, BCL2 is very weak focal, so it is not overwhelming. So, in a B cell population, if you see very strong expression of BCL2, then that's a clue that it is a low-grade lymphoma, and that's why we use this marker commonly. Now, this is a normal germinal center, and in the normal germinal center, a BCL2 is negative, and all other cells, because I told you in mantle cells, you'd have both T and B, and that's why there is some staining. But a germinal center does not have, except for the scattered follicular helper T cells, it does not have any other cells, and that's why it is negative. The MIP1, this is what I was talking to you about, the dark zone and the large zone. So the dark zone is where you have centroplasts which are proliferating, and the light zone is where you have all the centrocytes. So you have these cup-shaped kind of a MIP1 labeling in. So we use Ki67 as a marker to understand. Now, in a reactive process, Ki67 is like this. It's very uniform or maybe patchily increase in the paracortex, but it is not there elsewhere. Now, if I see a loss of MIP1 in the germinal center, I know that this follicular is neoplastic. If I see too high and uniform Ki67 in the paracortex, I know it's probably T cells are not just reactive, they're a little more than reactive. So we use a Ki67 cutoff of generally 40, between in the B cell lymphomas, it's very useful. Above 40%, you're generally looking at a high-grade lymphoma. Below 40%, you're looking at a low-grade lymphoma. So I trust Ki67 heavily as a marker for many of my differential diagnoses. Now, this is a CD21 and a 21 and a 23. They are positive in the germinal centers. Now, you can see this is these are thin whips of cells. So it's like a fibril kind of a positivity. Whereas if you have cell positivity, it's cytoplasmic staining. So this is the dendritic network that is getting stained in CD21 and 23, and we use it. Most importantly, we use it in angioblastic T-cell lymphoma, because in an angioblastic T-cell lymphoma, there is dendritic cell proliferation outside of the germinal center along the sinuses, and that is the most important diagnostic clue. How do you distinguish between neoplastic versus a reactive process? Now, number one is that if you have germinal center, if you have sinuses, then you're doing it at a reactive node. Except that some AITLs or angioblastic T-cell lymphomas absolutely occur in a reactive node, and they are often missed. We're looking at a lymphoma, if these germinal centers goes missing, the sinuses goes missing, and the nodal perinodal fat involvement is there. Now, how IHC helps in benign versus neoplastic? So number one is that you call something as a neoplastic B cell proliferation. I already told you the 20 is way more in excess of CD3. And not only should the CD20 be more, you should have an aberrant marker expression by the B cells. And aberrant, or so example, you have aberrant location of the expressing cell. For example, germinal center marker is 10 and BCL6. If I have the 10 and BCL6 in the interfollicular area, that means the germinal center cells have spilled into the interfollicular area, and that is a clue for a follicular lymphoma. Now, in neoplastic T cell proliferation, there's a little bit of problem, because whether benign or malignant, everything is CD3 positive. Then we look for clonality. Clonality means one type of cells only. So if you see only 4 positive cells, or if you see 8 positive cells, then you're dealing probably with a lymphoma. And if you have cells that are double positive for 4 or 8 or double negative, that's also an abnormal population of T cells. We look for the loss of 2, even 3 and 5 or 7. That's also an aberrant pattern. The most common antigen to be lost is CD7. Now, just to show you some reactive pattern. So what happens is that this is a germinal center. That's your centroblast area. And the blue collars are your mantles. Now, what happens in progressively transformed germinal centers? The mantle goes inside, eats away the germinal center, and you get a blue cell nodule like this. In a follicular lymphoma, the whole follicle is neoplastic. So you get this differentiation between light and dark areas of a follicle is totally lost. And that's why everything starts looking blue. You can see the contrast that you see here will never be seen in a follicular lymphoma. So let's look at the case. This is a 35-year-old male with a 2.5 centimeter node. Those of you who are not speaking, can you tell me whether you can see germinal centers in this? Okay, maybe I should keep talking and hopefully somebody is listening there. So you see what has happened here is that you have these germinal centers and this is your mantle. And the mantle is getting into the germinal center and breaking it up. And you can see the germinal centers are broken into many little follicles. Now this is what we call, this is just a high power of that. And this is what we call as progressively transferred germinal center. And this is a high power to show you that sometimes people mistake this for follicular lymphoma. And you can see that there's but however, the BCL2, because these are T cells, so they are BCL2 often positive. That's why you have to be vigilant not to call these as follicular lymphoma. Now let's look at basic examples of immunohistochemistry from lymphoma versus not lymphoma. Now, 45 female, large mass in the pelvis. Now this is the CD3, that's the CD20 and CD3. The 20 is not in excess of the CD3. So that is why it is definitely not a B-cell lymphoma. It is not a T-cell lymphoma either because the T is also not overwhelming. So this is probably a reactive proliferation and that's how we make a diagnosis of Castleman's disease. On the other hand, let us look at the similar kind of history, 45-year-old female with a large retroperitoneal mass. Now here, when you look at the lymphoid cells, they're very reactive. What do you mean reactive? They're very pycnotic small. When we go higher up, now look at these core. Now in this core, you can see that they're cleaved, they're irregular. So when you say changing profiles of the lymphoid cells, that's one of the clues that we're dealing with a lymphoma. Now let's look at the 20 and 3. You can see 20 is overwhelmingly positive and 3 is negative. Now, if I show an abnormal antigen expression like BCL2 or 43 in this, I have a diagnosis of a low-grade B-cell lymphoma, and this was a nodal marginal zone lymphoma. So this is how we go about diagnosing low-grade B-cell lymphomas. Now, let's look at T-cell lymphoma. So here is a 55-year-old man with multiple nodes, cervical nodes, and he's pretty fit. He's actually a doctor's father, and this is and it was diagnosed as T-cell lymphoma somewhere else. And you can see there's total loss of architecture. There's not a single germinal center in this node. And when I was talking to you, I will show you these cells later on. There are some abnormal cells. These are not the pycnotic looking cells. And when you do immunohistochemistry, they're strongly CD3 positive. The occasional cell, immunoblast positive with Eberish is also there, the 20. Now, it's very important to remember that while in a B cell proliferation, the T cells are often reactive. In a T-cell lymphoma, you always get large B cells. And I'll show you in the last few slides that these large B cells are the reason why T-cell lymphomas are often called as B-cell lymphomas. So here is a T-cell proliferation and you can see this immunoblasts, few of which are Eberish positive. And so you're almost comfortable and you see the CD8 very strongly diffusely positive. Now, when you see a situation like this, when you have 8 overwhelmingly positive, because most T-cell lymphomas are 4 positive, the one thing that you should do is ask for history of immunodeficiency. And even if this was a doctor's father, I always quote this case because you don't ask these embarrassing questions to, important people. And somehow somebody managed to ask, not me. And we came to know that this patient was actually HIV positive. And so in HIV positive, when you get a T-cell lymphoma report and from a pathologist who is it, and the patient is HIV positive, in that case, remember, call up because with an important history, whether the patient is on heart or not. Because if the patient is not on heart, then this is just a reactive cytotoxic T-cell proliferation. You give heart to the patient, the 4 and 8 ratio stabilizes and all these proliferations go away. You might even get clonality positive in this, but it is still not a lymphoma. So remember this. And that is the reason I think T-cell proliferations are such a nightmare for a pathologist because there is a very close overlap between reactive and neoplastic proliferation. So most important, I've already told you that how to distinguish between lymphoma or not. Now, what is the further approach? The further questions we asked is this a polymorphic? You'll see my reports. I write polymorphic proliferation, monomorphic proliferation. What does that mean? And each of this is followed by unique panel. If you have a monomorphic proliferation, the B cell panel is different. If you have a polymorphic proliferation, we usually think of different things. So when you see a monomorphic, that means all cells are looking like each other, then you generally mean that it's a lymphoma, except in a pediatric age group, viral infections will do the same thing. So then we look at the cell size and we put large cell panel, intermediate cell panel, and small cell panel. Now the large cell panel, in the B we think of DLBL, in the T we think of ALCL. Now intermediate size is a cell where it has very little cytoplasm and a very prominent nucleoma. Now, this is where all the blastic tumors lie, the lymphoblastic, Burkitt, blastoid. Now, what do you mean by size? What do we compare this size with? I'll come back to in a next slide. And mature is when you put a small cell panel. Of course, most commonly small cell lymphomas are B, but there are very rare T cell lymphomas that are also small cell. Now, when you say polymorphic, what do you mean by polymorphic? That means you all kinds of T, B, all kinds of cells, and yes, it's a lymphoma. The commonest diagnosis is a T cell lymphoma, but the DD being that there is a Hodgkin's lymphoma and reactive, that is a very close differential, and we'll look at it in the next few slides. So when I talk about cell size, I talk about the nucleus of a macrophage or an endothelial cell. That's an endothelial cell there, and that's the macrophage nucleus which is there. So any cell that is equal to the nucleus of a macrophage is an intermediate size cell. And this is where all the blastic tumors lie. Anything that is smaller than this is a small cell lymphoma, and anything that is larger than this is a large cell lymphoma. So when we talk about cells, this is what we mean. So these two are your small cell lymphomas, because I can't see an endothelial here, but here I can see, and these cells are much smaller than this. This is small cell lymphoma. These cells are much larger than this cell. So this is a large cell lymphoma. So once we come, now let's look at the low-grade lymphomas. Let's look at small cell proliferation. So predominantly B cell, 20 strong staining, small cells. Then we look at whether it is nodular, because if it's a nodular pattern, then the most common diagnosis is follicular lymphoma. And if it is nodular, but remember, nodular things can also be seen in CLL, SLL, mantle cell lymphoma. So what we look at is that we look at the type of pattern, and we'll look at that in a few while. Now, if you don't see a nodular pattern, the commonest diagnosis is SLL, CLL, but mantle cell lymphomas can also be that. And very rarely you can get a polymorphous small cell lymphoma, and that's usually a nodal marginal zone lymphoma, where you have plasma cells, lymphoid cells, histiocytes, all, and you don't think of B in the first shot. In fact, you think of T in these, and those are the kind of cells that you get in nodal marginal zone lymphoma, and that's why it's very difficult diagnosis often. So let's quickly go through the morphology of cells. So what we do is, this is an FNAC from a reactive node. The commonest cell there is this cell, which is what we call as Stockerball chromatin type of cell. And this cell is the cell of a CLL, SLL. Now, so this is the left-hand image is this SLL, CLL image. And you can see there are pro-lymphocytes within this. And these pro-lymphocytes are the source of dividing cells in SLL, CLL. Now, when this is a mantle cell lymphoma, you can see that the size is much larger, and it is the most bluest of all the low-grade lymphomas. And in a follicular lymphomas, so in a mantle cell lymphoma, you don't get large cells. You never get the large cells. The large cells are only seen in CLL, SLL, and follicular lymphoma. The lower profiles are of a follicular lymphoma. You get cleaved cells, and you get these centroblasts. And nodal marginal zone lymphoma can show you any kind of pattern, and that's why it becomes a problematic diagnosis sometimes. So let's look at some images. This is a 55-year-old man with, what can you see here? You can see a stuffed node. You can see the node that is absolutely bulbous, no sinuses. There is spillage into the perinodal fat, and you have germinal centers everywhere. You have these follicles everywhere. When you look under high power, you realize that these follicles lack the distinct mantle zones, because all the cells within the follicles have spilled outside, and the inside and outside is now the same, and that's why the distinctness of the follicles is not overwhelming. And that's the reason when you start thinking of a follicular lymphoma. So you see, as I go on the high power, very rarely, very little part of it is showing you preserved follicles. And when you look in the high power, they're entirely centrocytes. So this is abnormal. Remember what I told you? 1 centroblast, 3 centrocytes. That's the ratio that has to be maintained, at least approximately. And here, what are you getting? You're getting sheets and sheets of only cleaved cells. So this is an abnormal follicle, and that's a you do a 3 and 20, and you can see that the 320 is way more than 3:1 ratio. So this you are looking at a B cell lymphoma or follicular lymphoma. Now the 10 is the most important stage. You can see the 10 always stains benign as well as malignant follicles, but what you should see is the interfollicular spill that you see in the CD10 here. Some part of it is not showing staining because the interfollicular stain is not like a universal phenomena. This is the BCL2. You can see that all of the cells are positive for BCL2, and that's the reason, that's the most important diagnostic feature of follicular lymphoma. Now, MIP1 is very important. Remember what I told you? You get these very strongly staining. So, a normal follicle is very strongly staining in MIP1. And you can see here because of that apoptosis to kill the centrocytes. But look at these follicles. Absolutely no MIP1 there. Why? Because these are non-dividing follicles. Because these are centrocyte-rich follicles. There are no centroblasts, or there are many. You'll never get a follicle without centroblasts. So, there are very little centroblasts. And that's why this is a follicular lymphoma low grade. I think I did some mistake here. This is a wrong slide there. Okay, I think some slides are missing. I can come back to that later from some other presentation. Okay, so this is a 70-year-old man with cervical node and peripheral lymphocytosis. And lot of noise. Can somebody just switch up the mobiles, please? So anyway, so this is a 70-year-old man with peripheral blood lymphocytosis. Now, as opposed to that node where you saw total loss of architecture, in this node, what are you seeing? Absolutely one type of proliferation. There's nothing, there's no, and even a medical oncologist can call this lymphoma because there are no germinal center, there are no sinuses, there is just one mass of cells. And then when you look into hyper, what do you see? You see predominantly small cells. That's an endothelial cell, and most cells are smaller than that or a little maybe equal to that. You see large cells are popping out of these proliferation. And when it much noise, can people stop please? So anyway, so this is the small cells and these are large cells, and this is to show you that this is an endothelial cells, and all these are almost the same size because now these are not the perfect. This is an SLL-CLL, maybe with a little cytogenetic abnormality, and that's the reason it starts looking a little. Now, most important is what to look at the chromatin. It's exactly like the naive B cell that you get normally, and that is the, so you have a small cell type, you have large and small cells, it is diffuse. The most common diagnosis, this is just to show you the 20 and 3 in that lymph node. You can see aberrant marker expression, 20 and BCL2 are very similar. It's not similar to the 3. And you get a 20 here. This is the C3 here. Now, one interesting point is that the MIP1 is seen quite frequently high in CLL, SLL. And those are the growth centers which are rich in pro-lymphocytes. Doesn't mean anything. And that's CD23, which is positive. And that's a small lymphocytic lymphoma. And we use what we call as LEF1 or lymphoid enhancing factor very liberally because all CLLs are positive. So to me, this is a very good go-to marker. Except some follicular lymphoma, all other low-grade lymphomas are negative. So we finished just the small B cell part of the story. We look at the intermediate size of B cells. As I said, in a child, you're looking at T lymphoblastic and Burkitt's. In an adult, you're looking at blastoid mantle and myeloid leukemia. Now, this is the typical story of a 7-year-old boy who comes with abdominal ileocecal mark intussusception. What you find is a population of cells that is equal to the size of an endothelial cell. You will see this in the higher part next. That's a macrophage nucleus, and you can see that the cell is equal to the macrophage nucleus. And what is important to see is that it has very tiny but very prominent nucleoli. You see these little faces that these Burkitt lymphoma cells make. So if you see prominent nucleoli, larger cells, that is when we call as Burkitt-like and Burkittoid or some weird names that we use, or atypical Burkitt. And the perfect Burkitt is what I'm showing you now. And of course, the 20 and 10 Burkitt is a germinal center tumor. So it will express 10, 20. It will be negative for BCL2 because this Burkitt's lymphoma, the cell does not enter the germinal center. So it is BCL2 negative. and it is MIB1 high and it intensive chemotherapy regimens. This, on the other hand, is a mediastinal mass. Again, an intermediate site tumor. You can see that's the macrophage nucleus, almost similar to that. But as opposed to Burkitt's lymphoma, no nucleoli, very finely stippled chromatin and very, very fine cells. And that's why sometimes in a mediastinal mass, due to crushing, we don't ever see proper morphology because this tumor is fragile. And that's the important, this is just to show you the high part, to show you the this is your endothelial cell nucleus. This is a little elongated, but same size. And you can see the very, very finely stippled chromatin, no nucleoli. This is the diagnostic feature of this lymphoma. This is a mediastinal mass. So the common and differential, because T lymphoblastic lymphoma and thymoma share identical immunoprofiles, we do a epithelial marker to ensure that within that lymphoid proliferation, there are no epithelial cells. And this is the TDT, and there are no epithelial cells, and that is how we make a diagnosis. Now, another marker we do is LMO2, because LMO2 is not seen in normal thymus, it's only seen in immature cells of lymphoblastic lymphoma. So, now we come to the large cell proliferation. As I said, large B cell 20 positive proliferation is DLBL. Large T or null is anaplastic large cell lymphoma. So you see this, you see that lots of tingible body macrophages because of very proliferative tumor. And you can see when I talk of large cell lymphoma, that's a macrophage nucleus. You can see the heterogeneity of the size. It is all larger than that, but you can see none two cells are same. And that's the reason DLBLs has often, they are often a difficult diagnosis for most pathologists and in terms of prognostication, not in terms of diagnosis. So then we come to the polymorphic lymphoid proliferations, and you can see, I told you that the paracortex is the site for most of these proliferation. You can get T cell lymphomas there, you can Hodgkin's there, and you get reactive cells. The difference is understanding that the T cells are neoplastic. And how do you realize that T cells are neoplastic? By either seeing the T cell atypia and you see aberrant antigen expression. Now, T cell atypia is something that is destroyed in poor fixed biopsies, and that's why we often struggle in out-in material. Now let's look at this 60-year-old very sick patient with a high LDH, generalized lymphadenopathy, total loss of architecture, not even a single germinal center there. Okay, I go into the high power and I start seeing these little cells which are larger than the normal lymphoid cells. They're very cleaved, and you have scattered immunoblasts, which, remember, B cells will always be there in a T cell lymphoma. And you see this high endothelial venue. Because of the loss of architecture, because of the clinical presentation of lymphoma, I just need to add a few markers and I am good to on the diagnosis of PTCL. And you can see 3 positivity. As I said, 20 and 30 positive cells are always there in T cell lymphomas. 7 is lost. You can see compared to the 3, the 7 is much, much less. And then we do markers for 4 and 8. Now, this particular case, you can see 4 and 8 is equal. So this is double positive for 4 and 8. And that's the MIB1, which is very high. And that's how we make a diagnosis of PTCL. This case I've already shown you. I will skip this. I'm sorry. These are some copy paste slides. So why is the diagnosis of T cell lymphoma different? Because the neoplastic population is very sometimes small and it shows 8 for both combination. You have a whole lot of inflammatory cells and you have B cells and endothelial cells. Now, in any given cell, you can get prominence of one of these cells and it can confuse the picture. And I'll show you in the next. So, example, this is T cell lymphoma. Now, sometimes you can get, these are the large B cells. Imagine a case where these large B cells proliferate. Now, they're not neoplastic, but they will just overwhelm the picture and will result in a diagnosis of B cell lymphoma. Sometimes they look like HRA cells, so we call them as Hodgkin's. And sometimes the atypia in the T cells, especially the finding. So neoplastic T cells have a very clear cytoplasm that if you don't appreciate, then you end up calling it as a reactive process. And this is the WHO classification. We call now nodal PTCL as nodal follicular helper T cell lymphomas if they're expressing follicular helper T cell markers, PTCL NOS, and we have EBV positive nodal NK T cell lymphomas. There are 2 classifications of lymphomas now, and these are the 2 references if you want to read. So what is the algorithm to the diagnosis of T cell lymphomas? As I told you already, 3, 7, 4, 8. 2 is never lost in mature T cell lymphomas, but 2 is very important to find out the lineage in T lymphoblastic lymphomas. It's the last to go marker. So the marker we do first, so you have to look at the morphology. If you have a T cell lymphoma and it is blastic, rule out a lymphoblastic lymphoma. Then if it is large cell type, then rule out an AL cell. Another type of large cell lymphoma that is seen is CD50, is an NK cell lymphoma, so do a CD56. Now, after ruling out these all, then what remains is an extremely polymorphic kind of a proliferation with high endothelial cells and clear cells. Then we do the follicular helper T cell markers. If they're positive, we go according to the WHO. And if they're negative, we call them PTCL NOS. Then we do a cytotoxic marker, EBER-ish, to classify them as PTCL NOS with EBV positivity or negativity. And then we are supposed to do TBX21 and GATA3 in all PTCLs. Unfortunately, I'm not at least happy with the results of our TBX21 in these populations. So let's look at some T cell lymphomas. So there's a 55-year-old man with multiple typical very poor GC. Lab investigations talk about raised immunoglobulins, and the patient typically gives you a history of skin rash after crowsing. And if you look at this, what do you see? These are the scanner images. And what you can see is that around the sinuses, where you normally get T cells, that's where the B cells are. So there's a swap. And the T cells are overwhelming in the rest of the node. Now let's look at the higher part. Absolutely loss of architecture. But what we see is some pale nodules sticking out. Now let's look at what these pale nodules are. Well, these pale nodules are of these little beautiful clear cells. This is a very wonderful photograph. It's what we say, it's a pleasure to see such kind of processed nodes. So these are your little clear cells. The larger cells are the B cells, but all these cells have these are T cells which have little bit of clear cytoplasm, and these are the ones that carry frequently the IDH2 mutations. And see the clear cells in the higher part, and they usually surround the high endothelial venues that you can see. So what am I seeing? I'm seeing clear cells, I'm seeing high endothelial venues, I'm already seeing a very polymorphous population. So my diagnosis towards PTCL is made. Only thing the clear cells tell me that this is a follicular helper T cell lymphoma, because clear cells generally are seen in our follicular helper T cell lymphomas. We do a 3 is overwhelming, 7 is partly lost, not completely lost. These are just the high pass. And look at the MIB1, uniformly high, though you may have patches of little more intensity. So that's the clue that these are not normal. If you remember the reactive node, very uniform little cells, but T cells highlighting such strongly, no other differential diagnosis. Now that's a 4, way more than 8. So it's a clonal 4 population. I do my follicular markers, PD1, CXL13, both are strongly positive. This is one of the cases where CXL never works, but it worked. And then what I do is I do a dendritic cell marker, because to differentiate between the different, one of the most diagnostic marker for this lymphoma is presence of extrafollicular dendritic cell expansion. Now, I want you to see that wherever the B was, you see dendritic cells there now, because what has happened is the germinal centers have collapsed into the sinuses, and from there, this dendritic network is coming into the node. So this is what is called as an extrafollicular dendritic cell expansion. And you can see that it is there along the sinuses, and it is just creeping into the node. And this is just a high power of that. So that makes your diagnosis of angioblastic T cell lymphoma, nodal follicular helper T cell lymphoma. Now, this is another case, and you see that this person had been treated as Hodgkin's, received 2 ABDD, but he had lots of residual disease, and he had Waldier's ring involvement, which is unusual in an adult with Hodgkin's lymphoma. In children, you do get it, but in an adult, it's unusual. So when you go on the higher part, what you see is, you see this, nodular kind of pattern. Of course, you see these RS cells. What happens to pathologists when they see RS cells, everything else blurs. But when you go on the higher part, you see that the background cells are clear. They are not reactive. And that is the first clue to the diagnosis of PTCL with Reed-Sternberg cells. So that is the reason we struggle. We are not, with the diagnosis. So we do the immunohistochemistry T. You can see this is a T overwhelming presence, 20 is very little. And the interesting part with 30, and I always use this, that not only are your RS, but you're also seeing a large part of these small T cells that are staining with 30. And to me, this is the diagnostic marker for T cell lymphoma. The marker, the profile of those Reed-Sternberg cells will be identical to Hodgkin's. It's the background that will tell you that this is an abnormal background. That is your MIB1 to tell you that the background, I really use MIB1 as a very strong differentiator. And that's your 4 positive, and it has a little NLPHL-like pattern, if I may say so. And so how do you differentiate a patient from an Hodgkin's with a PTCL with Rh-like cells? You must recognize the atypical T cell problems. You must show a loss of clonality of T cells. And in this particular patient, there was a tonsillar mass biopsy which did not have Reed-Sternberg cells. So that was a clue, because if it was a Hodgkin's lymphoma, Hodgkin's will be the RS cells will be everywhere. And another thing is resistant behavior. And of course, clonality helps. So what is this clonality? So what happens in normal cells, we have polymorphous cells, each of them carrying a different so VDJ rearrangement occurs, and they carry a different label. Like this will say this guy is the green, yellow, red, blue. So when I fragment this nuclei and run it on a gel, what I see is different shapes of different lengths of band, because each of them have their electrophorus differently. On the other hand, if all cells carry the same T cell receptor rearrangement, they'll be seen as one single band on gel electrophoresis, and that is what we mean by clonality. We don't use gel anymore, we use capillary electrophoresis. And the next photograph you see is of the capillary electrophoresis, and you can see that that's a positive control. And in the same area, you can see that the tumor cells are showing the TCR beta gene is showing a clonal population of cells. So if you see this kind of a peak, that's polyclonal. If you see one peak standing out of the rest, this is clonal in a polyclonal background. So this is positive for T cell clonality. But mind you, in many of the cases of T cell lymphoma, clonality may be negative because only part of the entire gene is in it. That's why we have NGS for clonality as well. And lymphomas are dynamic, and especially in T cell lymphomas, the T cell population is very small. So that's why flow sometimes becomes very important, because you can pick up a small population and then do clonality only in that. So sometimes when you get negativity for, you are struggling with T cell versus Hodgkin's, maybe mutations will help, because RHO, TET2 and IDH2 are some of the mutations, out of which TET2 and DNN2 are really, really high frequency. That means most of the cells carry this. And that's why these are associated what we call with clonal hematopoiesis of CHIP. And that's a talk for another day. So let's look at another case, this time a younger male with extensive lymph node and extranodal involvement. And what you see is obviously diffuse kind of process. And when you look at them, you see this horseshoe-shaped nuclei. And these are very typical. These are called as the hallmark cells. And the cytoplasm of most of these cells is blue. They are large cells. You can see that this is an endothelial cell. They are way more bigger than that. So this is a large cell lymphoma. When you do a 3 and 20, both are negative. It has a null cell phenotype. So the next marker you do is CD30. And this, you can see a very nice complete membrane and Golgi staining pattern, which is classical of anaplastic large cell lymphoma. When we do an ALK, this is a cytoplasmic ALK. The ALK staining depends on the type of translocation. If you have nucleophosmin, then you get nuclear. Otherwise, most of them have cytoplasmic kind of staining. Now, here is a boy who is solitary MIB mass. He is ALK negative ALCL. Now, pediatric ALK negative ALCLs are extremely rare, but this was one such case. And now the problem was that how do you treat? Do you go full ALCL or you don't? And now we know that ALCL has different markers. You can do this double fish for DUS22 and TP63. And the TP63 is associated with poor prognosis, whereas the DUS22 is the better prognosis. Now, this is a lady who actually came with an ulcer on the cervix. A biopsy was taken. This was the older days when we could see all the biopsies from all sides. And you see it was a lymphoma. It was a very frank lymphoma. 20 was negative, 3 was positive. So extranodal site, 3 positive tumors. So anybody wants to say anything? Now let's see, early morning lecture, all of you are sleeping, almost nearing the end of the lecture. All these markers were negative, only 7 was positive. So when you see a 3 positive and a 7 positive combination, you also will get 30 focally. So this is the other thing that is there, and that is NK cell lymphoma. So this was an NK cell lymphoma in the cervix. So the diagnosis of NK cell lymphoma in a nasal site, in a non-nasal location, requires not only just EBV, but it also requires cytotoxic granule proteins like TI1. Granzyme is the most common one, besides, of course, the CD56. And if you don't get these markers, then we call it a gray zone lymphoma. So to conclude, I think well-processed node and clinical input sometimes are required for a diagnosis of lymphoma. A reactive node has more story to tell than any other lymphoma. a lymphoma diagnosis is based on attention to architecture, pattern, individual cell morphology. And remember that there are diagnostic gray zones. There were many cases, but I deleted them because I thought early in the morning, the Gaussian bar sometimes goes down. So lymphoma diagnosis is like performing the asanas. You go on morphology, immunohistochemistry, and make sure that you remain, the diagnosis remains fit and healthy. Thank you so much. Are there any questions from anybody?
Thank you, ma'am. Ma'am, just one thing, this immunoblasts, like where would you put it and how does it?
I thought you told me Hodgkin's ka another lecture lena hai. So mere bahut sara, actually this is a 1.5 year old, hour lecture. I cut down many slides. So immunoblasts basically in the what I showed you in the T cell lymphoma, they look identical to that. So they can mimic RS cells. They are almost similar. Wait, okay. Do you want me to show some case to you just now? Or should we
like how, I mean, how are they useful for B cell lymphomas? B cell lymphomas anywhere they're important in diagnosis.
Sorry, Alok, I could not get that question.
B cell lymphomas, like how any point they help in diagnosis or their characteristically find in any type of the B cell lymphoma.
So you're talking of immunoblast in DLBL?
Yes. Or
so immunoblast is a cell which is a blue cell with a very prominent nucleolus. Now that's a morphology that you see with EBV infection most commonly. When they're scattered in the paracortex, that's a reactive process. But when they come in sheets, it's a DLBL. Immunoblastic DLBLs are usually post-germinal center type. So they are MUM1 positive. And the EBV is a very common thing. And they are more aggressive than most of the other lymphomas. In the older, there was a German study which said that immunoblastic morphology is associated with resistant behavior to R-CHOP. But that's about it. These days, nobody pays attention to morphology. Does that answer your question?
Yes, ma'am, somewhat.
So, Alok, what we are talking is the immunoblastic DLBLs, where the type of DLBL which is the typical AIDS defining DLBL, which were, the pre-heart era, that was typically ABC subtype, MUM1 positive. So that's how the immunoblastic and centroblastic classification was in DLBL. But nowadays we don't really do that. Am I correct, ma'am?
Yes, yes. But so the thing is that immunoblastic is a morphologic thing. So you have to combine the immunoblastic morphology with the immunophenotype. So it's a good thing that if I have an immunoblastic morphology and I have expression of germinal center markers, that's where the double hit lymphomas lie. So yes, morphology, sometimes immunoblastic does help in sorting out some of these problems for us.
Any questions? Residents? Yes, ma'am.
Good morning, ma'am. Ki67 and MIB1, they are interchangeably used at many places. How different are they, and what is the concordance like?
So there's somebody who understands pathology. Very good. So MIB1 is the DACO specific antibody. So Ki67 is the marker, and the DACO antibody which is used for most of these, in breast, actually that's the most validated one. So the MIB1 of DACO, so the DACO antibody if you're using, we call it MIB1. Otherwise, we call it, or if you're not using the DACO, you call it Ki67. Does that answer your question? So Ki67 is the original protein, and MIB1 is a label. So if you clones, what happens is, suppose I have, for example, HER2, and I have different clones. So if I have the FDA HER2, I call it HER2. If it is non-FDA, I call it CFB2. So the protein is CFB2, and that's the reason. So Ki67 is the protein, and MIB1 is the clone, which is validated by the DACO company who sells that antibody. And MIB1, if you're doing, you can't use the word MIB1 for a non-DACO antibody. That's the kind. So if I'm using, say, Ventana, I call it Ki67. Does that answer your question?
Yes, ma'am. And the concordance between the two?
Only MIB1 of DACO should be used. Both studies are validated on that, because other MIB1s are variable. So we actually introduced a Ventana, MIB1 Ki67 recently, and we got overstaining within the lymphomas, and that's why we discontinued it. I think MIB1 is a very good antibody from DECO. We don't encourage other Ki67s because most of the studies have been validated with MIB1 DECO, and that's why we use a lot of in breast cancer, and breast cancer recommends only DECO MIB1, and that's why we don't do elsewhere.
Thank you. So K67, you know what K stands for? What is K?
Sorry?
No, ma'am, I'm asking residents. I think all of you know, right, what is K stands for in K67. It is the name of the city where it was discovered. The city in Germany. Google it. Okay. And any questions? No questions. Arvind? Yes. Okay. So I think there are no questions from anyone from any question chat box. Can you just see us?
Somebody has written Keel. The Keel spelling is wrong, but it is correct. Ki67 stands for Keel. So
So-
Ki67 and CD30 were discovered in Keel at the same time, and in anaplastic large cell lymphoma.
Okay, so I think there are no further questions. And thank you so much for the
Thank
wonderful.
you. Sorry, I had to cut it down short. Maybe some other day I'm ready
Yeah.
to take more also. Thank you. Thank you.
Thank you.